Hello, everybody, and welcome to Hughes Clues Clinical Application of Hemodynamics. Within this recording, you're going to learn how to answer the exam questions on hemodynamics. There's usually about 4 or 5 questions, and 4 of them, if you've done these modules, are going to be pretty easy for you to answer. There's going to be one that might present somewhat of a challenge for you, but you're still going to be able to answer it with some thought. And then in addition, you're going to be able to take care of your patient, probably the most important thing, and apply this information that you learned in the part 1 of the recording. When you are faced with a bunch of hemodynamic data, first look at all the values. Stay calm and look at all the values that tell you about the volume status of the patient. You have to know if the patient is volume overloaded or whether their volume status is deplete. And so when I say the tank is empty, that's what I'm talking about, their vascular space. So the rule is that if the tank or vascular space is empty, then you should fill it by filling it with the IV fluids or blood or some kind of volume expander, such as albumin. If the tank is full, however, you want to empty it, so consider a diuretic. There are different types of diuretics, pretty much mostly in this course we use Lasix. And then there's also, as you configure what's going on with these hemodynamic values, trying to consider what the problem is. And again, I'll show you that as we go along. Fix the problem first. Don't fix such as things like compensation first, but fix the problem first. There are all kinds of different medications, and if you look at page 9 of the hemodynamic worksheet, you'll see that I've pretty much given you all the values that you need to know, as well as the medications that are need to know. And if you put each of those medications in what I call a box, in other words, put it in their category, you won't get these medications confused. I know they look pretty simple when you're looking at it in isolation, but when you're in a test, you're kind of stressed, and so put all the positive inotropes together in a list, put all the vasopressors together in the list so that you can easily identify what class these medications are in. Take a deep breath and relax. Most of my practice questions, or some of my practice questions, are actually harder than when you're going to have on the exam. Know that Dr. Reed will only give you one problem at a time to fix. And the big key here is do not equate systemic vascular resistance with blood pressure. I did clarify and correct my mistake on the original hemodynamics part 1. SVR does not equal blood pressure. Yes, systemic vascular resistance does relate to the state of the artery and it can affect the blood pressure, but you cannot say categorically that if the SVR is high, the blood pressure is high. They just don't go together. Email me if you have questions about that. So let's look at this first problem. If you want to play along and figure this out on your own, pause the recording and then see if your answer fits the same with mine. If you're kind of confused about this very complex topic, then just keep listening. There are plenty of practice questions that are totally different than what I have here, and you can get lots of practice doing this or configuring this on your own. So let's look first at the values. As I said, choose or look at the values that tell us about volume. So in this laundry list of values, which one tells me about volume? Well, we're just going to start at the top, and we can say that we know that the CVP tells us about volume. The CVP of this particular patient scenario is 1. So tell me about that. Well, the CVP is low. What does that mean? Well, it means that the volume on the right side of the heart is low. So the CVP of 1, right atrial pressure, tells you about the volume on the right side, and it's low. Then we look at the pulmonary artery pressure, PAP. We see, yes, 2 numbers, but we don't care about the systolic. We only care about the diastolic, the pulmonary artery diastolic, the PAD. The PAD normal is 4 to 12. The PAD is low, so therefore the volume on the left side is low also. I usually then look at the cardiac output. The cardiac index, which is the cardiac output adjusted for height and weight, cardiac index is low. It's 1.8. Normal is 2.4 to 4. You don't have to memorize these values. Put them down on your exam sheet. So the cardiac index is low, which means that there is a diminished cardiac output. Now, why would there be a decreased cardiac output? Well, when you look at the fact that there is low volume, that the patient has a fluid volume deficit, that makes sense. If the volume going into the heart or returning to the heart is low, then it stands to reason that if less goes in, less is going to come out. So the cardiac output is low because there is less volume. Then we see that the systemic vascular resistance is high. The SVR should be between 8 and 1200, and it's high. Well, why would the SVR be elevated? Well, remember that whenever the cardiac output goes down, the kidneys complain. They need a lot of cardiac output to filter the blood throughout the day. So whenever the cardiac output goes down, then the kidneys will secrete renin. Renin will ultimately turn into angiotensin II, and that will cause vasoconstrictin to move the volume that's left in the body into the core. If this does not make sense to you, then email me. You have to understand compensation to be successful on exam 2. So we know that the low cardiac output has caused compensation, and that is why the systemic vascular resistance is elevated. Now we look at the heart rate. Well, we can tell that normal is 60 to 100, and the heart rate is elevated. So why would the heart rate be elevated? Well, again, the answer is the same. It is because of compensation. How? What happens? Well, as soon as the cardiac output goes down, the baroreceptors that are in the aorta, it's kind of like a balloon, and if the balloon doesn't blow up very much because there isn't a lot of cardiac output, then that decrease in the baroreceptors, that decrease or sensation of less pressure or less volume in those baroreceptors will immediately activate the sympathetic nervous system. That actually happens faster because it's a pressure sensation before the RAS. And so this is why your heart rate goes up. Also, it is a sympathetic nervous system activation or compensation mechanism. All right, so what's the fix? If we have this thing going on, we can see that there's 2 compensation problems. We're not going to fix those first. We see that the cardiac index is low, but the cardiac index is low as a result of low volume. So this should be easy. The tank or the vascular space is empty. Fill it. So let's fill it with fluids. Normal saline is a really good option. D5W is not a good option. It does not stay in the vascular space, but normal saline mostly does. Or Ringer's lactate, lactated Ringer's. Ringer's lactate is not a good consideration if the patient has renal failure. Because it's an iffy one, probably saline is a better first option if you don't know much about the patient. Albumin, that is a volume expander, and then blood products. Now, you know that normal saline can fill the tank. Piece of cake. It's going to fill the tank, and it'll help kind of alleviate all these problems or the volume problem that has occurred. And so only blood products will likely be given if blood is lost, such as in a trauma scenario or a patient that has GI bleeding. So always consider that. If blood is lost, then blood is the best thing because we know that normal saline cannot carry oxygen. Normal saline will fill the tank. It'll be perfectly fine even if it's a trauma patient, but it is not going to help their oxygenation status. Blood lost, blood is needed to refill the tank. Any questions on that, then email me. Otherwise, let's move on to the next one. We have a different scenario, and we use the same process for this problem. We look at the values that tell us about volume first. So we look at the CVP. We see that the CVP is 15. The volume on the right side is elevated. A normal CVP should be somewhere between 2 to 8 millimeters of mercury. The CVP is 15. The volume on the right side of the heart is high. Then we looked at the pulmonary artery pressure, the PAP, and we're only going to look at the pulmonary artery diastolic pressure. We see that it's 22. Normal is 4 to 12. The volume is high because the pressure is high. The volume should be 4 to 12, or the PAD, should be 4 to 12. It is 22. Therefore, the pressure is high, and therefore the volume is high, because pressure equals volume. So the volume on the left side of the heart is high. Then we see that the cardiac output, or the cardiac index, the cardiac output adjusted for size and weight, is 1.8. The cardiac index is low. Why would the cardiac output be low? In the presence of a lot of volume, if there is enough volume, the cardiac output should be normal, because if the heart is doing what it's supposed to do, which is pumping blood forward, if there was a lot of volume that was going to the heart, then the heart's job is to pump that blood forward. And if there is not a decent or a normal cardiac output in the presence of a lot of volume, then this is a contractility issue. Again, the heart's job is to pump blood forward. If there is plenty of volume and the cardiac output is low, then the heart is not doing its job. It's not pumping. Therefore, that is a contractility issue. You can say that as every time that is the case in our course. Now, can there be some exceptions to the rule? Well, of course there can. And those complex exceptions you're going to figure out once you're a registered nurse if you work in the critical care area. But for our course, if the volume is high and the cardiac output is low, the heart's not doing its job. My heart is very healthy. If I drank 4 liters of fluid, then yes, I would have a volume overload for a few minutes, and then the heart would just eventually keep pumping all that volume out and about, and I would eventually pee it out. So the cardiac output, my cardiac output, would go up in the presence of high volume. Now, again, if there is plenty of volume and a low cardiac output, it is a contractility issue. Now we look at the SVR. The SVR is 2000. The SVR, systemic vascular resistance, is elevated, again, for the same reason. It is compensation for the low cardiac output. And the kidneys are basically an organ with blinders. The kidneys do not know what's happening in the whole body. The kidneys do not know that the heart is weak. All the kidneys recognize is, yo, I got to filter blood. I need cardiac output, and a lot of it, for every beat or for every minute. And when the cardiac output goes down, regardless of the reason, whether it's a volume depletion or volume overload, they don't care what the problem is. The kidneys just recognize that they're not getting enough of a cardiac output, and therefore they will initiate the RAS. Same thing with the heart rate going up. The heart rate goes up, and because of the low cardiac output, the baroreceptors, again, they don't care that there's plenty of volume. All they recognize is that the cardiac output is low, and they will activate the sympathetic nervous system to increase the heart rate. Again, email me with questions if it's hard to wrap your head around this. So what's the fix for this? Well, what did we identify as one of the problems? The problem is there's a lot of volume. And in a weak heart, a lot of volume is very problematic. The tank is full. We need to empty it first. How do we empty the tank? With diuretics. So we give diuretics to try and decrease the volume. And Lasix, again, is always a good choice, though there are other options. That's a physician to decide. You just need to recognize that your patient needs some kind of diuretic to get rid of this excess volume. Let's move on to the next scenario, and we're going to really have a continuation of what the previous problem was. So we had in the previous problem too much volume, and there was too much volume, and the heart had a poor contractility issue. So the first thing we did was give Lasix, or some kind of diuretic. We want to get rid of the volume so that we can kind of help the heart decrease its workload. And so let's get rid of the volume. And when we see this scenario, because you may not get the previous scenario first, you may just get this scenario, you can see that when we look at the values that tell us about volume, we can see that the CVP is 8. So the CVP is normal. This patient likely has diuresed, and the volume on the right side is now at a normal level. Then we look at the pulmonary artery pressure, and we see that the pulmonary artery diastolic pressure is 12. Normal is 4 to 12, so we have a normal volume on the left side of the heart. But then when we look at the cardiac output or cardiac index, we can see that the cardiac index is low. So we have a low cardiac output, and again, because there is plenty of volume that is available for each side of the heart to pump, when there is a low cardiac output in the presence of enough volume, then we know that there is a contractility issue. The heart is not pumping as well as it should. Now, we still have a low cardiac output, and because there is less cardiac output, the kidneys are still deploying the RAS. Renin is still present with angiotensin ultimately 2, and therefore we still have a systemic vascular resistance or a vasoconstricted state in the arterial bed. And of course, the same reason that the heart rate is still high, because again, the cardiac output remains low. Well, what's the fix for this? Well, it's a contractility issue. So for a contractility issue, we need to give a positive inotrope. If you look on the sheet that has the listing of all of the positive inotropes, you'll note that there's quite a few options to choose from. You will not be asked by Dr. Reed to pick between the different options, whether you should give dopamine or dobutamine, because that's a physician decision. You need to just be aware as a nurse that several positive inotropes are an option to be administered, and your patient needs one of those options. Notice that DIG is the last one on the list. DIG is probably a drug that you're fairly familiar with. I haven't given that drug since, I don't know, the 1980s, because DIG in an acute setting such as this, when you have this patient that's critically ill and whose cardiac index or output is poor, you're not going to give some IV push digoxin. It's not going to be effective or as effective as giving one of these other positive inotropes. So these are the drugs that are indicated for a contractility issue. Now, you might also note, if you've had a moment to look at that sheet and see all of the drugs, you might notice that dopamine and epinephrine are in two different places, that they can also cause some other actions. And these actions or different actions are very dependent on the dose. Because in this course, you're not responsible for understanding or knowing the different doses and how they affect the hemodynamics, you just have to be aware that dopamine can be in the positive inotrope or can be given as a positive inotrope, but it can also be given as a vasopressor. And so when you look at the scenario, you just have to consider, well, what role or what hat does dopamine wear at this moment? Is it a positive inotrope, but also consider that its action could be doing something else? So that's just something to consider. But again, when you know that you have a contractility issue, one of these drugs, dopamine, dobutamine, bromurone, or epinephrine, and even digoxin may be an option. Now let's look at the scenario, or another scenario you can consider that it's continuation. If the patient's already been given Lasix and they also have the positive inotrope on board, and then here are the hemodynamic values that you see next. Again, we approach it in the same manner. You look at the values that tell you about volume, and the CVP is 8, and so therefore we know that the volume on the right side of the heart is normal. A pulmonary artery wedge pressure is 12. This tells me about the volume on the left side, and a PAWP of 6 to 12 is normal, so the volume on the left side is normal. We have normal value of volume, so that the volume status in this patient is good. Then we look at the cardiac index, the cardiac output adjusted for body size, and we see that the cardiac index is 2.5. That's awesome. The cardiac output, the contractility effect of the heart is doing great. But then we see that the SVR is 2,000. The SVR is 2000, and that is high. The artery is vasoconstricted. So why would it be high? Well, either there is still some problems that are going on in the heart or in the body that we don't know about, that vasoconstriction is occurring. It doesn't really matter what the cause. What we see is that you have an SVR that's elevated, systemic vascular resistance that's elevated. What does that mean to the heart? Well, it means that the left ventricle, who has or who may be weak, so the left ventricle, which may be weak, is having to pump or push or eject blood out into a systemic vascular system that is vasoconstricted. And that means there is much more resistance. If the systemic vascular resistance is high, then that means that or the value is high, then the resistance is high. And when the resistance is high, that means that there is much more work that the left ventricle has to do to push blood out. There is resistance in the aorta or in the systemic vascular blood vessels, and so therefore it is much more work for that left ventricle to push blood out. We don't want to stress out the left ventricle, especially if it's weak. So we could perhaps do something that will help that situation. Notice that the heart rate is okay. So really the only thing that is abnormal in this scenario is the systemic vascular resistance. So because the artery is offering a lot of resistance, and that is increasing the heart's workload, we need to give an arterial vasodilator to decrease the workload of the heart. So options for an arterial vasodilator would include nitroprusside, its common name is nipride, and nicardipine or cardine. Both of these drugs will vasodilate the arterial bed and will help to decrease the systemic vascular resistance and therefore decrease the workload. I tried to give the generic term, but sometimes I forget because I'm such a name brand person, and so just be aware and remember that you need to know the generic because that's what's going to be on the critical care exam. So it's at this point that you can stop the recording, that all required information that is needed to pass the course and to be successful on exam 2 and the final has been delivered. If you have more questions, then keep going. So I've got some more advanced concepts, and the reason why I did this is because I've had multiple questions from students who have inquiring minds and who are interested in critical care as a career. And so if you are that student, then just keep going. Otherwise, you can stop the recording and move on. All right, so let's say that a patient presents and you see these values. Let's, again, do the fix like what we know that we should do. We're going to look at the values that tell us about volume first. And when we look at the CVP, we can see that it's 12. So the CVP is elevated. The volume on the right side of the heart. The right side of the heart is high. And then when we look at the pulmonary artery wedge pressure, we also see that it's high, and therefore we know that the volume on the left side is high. The cardiac index is low. It's a little low. It's 2.2. Normal is 2.4. So we do see that the cardiac output is lowish, and there's a contractility issue. And then we can see that the systemic vascular resistance is actually normal and the heart rate's normal. So what kind of scenario might this present? Well, this could be a scenario where we have a patient who perhaps has renal failure. And you can see that if we wanted to get rid of the volume, because we can see that the cardiac index, cardiac output is kind of low, and that maybe the heart is somewhat weak, and that excess volume is causing a problem. Not a bad problem, but it's starting to cause a problem. And let's say that this patient came in and they were profoundly short of breath, and we really do need to offload some of that volume in or returning to the heart so that we can get them to where their symptoms of dyspnea will improve. Well, the patient has end-stage renal disease. They're on dialysis, and the physician in the emergency department has called in the dialysis nurse, but it's going to take them an hour to get there. We really don't want this patient to continue to have respiratory difficulty. And we definitely don't want them to have a respiratory compromise where they have to be intubated. So what could a fix be if a patient either didn't respond to a diuretic in a previous scenario because their kidneys are poor, or if a patient doesn't have kidney function, if it is in they're on dialysis? So what could the fix be? Well, the fix could be that there is increased preload, and so the physician may say, you know what, if we just decrease the amount of blood that returns to the right side of the heart, then this will offload or diminish the venous return, and therefore it can help the heart kind of kick back up and maybe do a better job with its pump factor or contractility issue. So if a venous vasodilator is administered, then therefore the venous vessels will dilate, blood will kind of stay to in the feet and therefore not go back to the heart, and therefore this can reduce the cardiac workload. It's going to provide somewhat of a temporary fix because the permanent fix would be to get rid of that excess volume, but it will help in a critical situation, in a critically acute situation, and even individuals who have renal function but who are just not responding fast enough to the diuretic. This may be a maneuver that may be an option. Now, one of the venous vasodilators that could be administered is nitroglycerin. Another venous dilator is nitroprusside, and we already talked about that as an arterial vasodilator. Well, the good news about nitroprusside is that it will dilate venous and arterial bed, and so therefore you can kind of get a twofer effect to where it will help on both sides of the heart so that we can really help the heart, especially if the patient has right-sided heart failure like this one does, and left-sided heart failure. And that's why I say, well, right side of the heart, left side of the heart, because that way you can figure out, well, is it left side, right-sided failure, or both? So again, email me if you have any questions about this. You do have to realize that nitroglycerin is a venous vasodilator, and nitroprusside is an arterial and venous vasodilator. This will kind of help you as you give medications. Now, one of the things that I always get questions from students is, so will you be asked to choose between drugs in the same class? And I'll say it again, no, you won't. Dr. Reed is not wanting you to be physicians or nurse practitioners and prescribers. Dr. Reed just wants you to be aware of what is it that you expect the physician to prescribe. So you won't be asked to choose between drugs that are in the same class. I often get the question, well, wait a minute, in one of the scenarios that we did, the patient clearly, yes, was volume overloaded, but the volume overload was present as well as a contractility. And it stands to reason that the contractility really is the major problem, so why not do that first? Well, I think what you have to remember is that the tank should be emptied, because any patient with heart failure, if you go back to the patho of heart failure, there is volume overload. That's kind of like goes hand in hand with heart failure. And really, we do need to offload or reduce the workload of the patient by giving the diuretic. But truly in the real world, it's only a matter of minutes before not only the diuretic, but the positive inotrope are given. But I do separate it out because you can sometimes be asked, well, what should you give first? And so, this is nursing exam world, and so we usually give the diuretic first because it's very easy to just shove Lasix in an IV push manner, whereas when you do a positive inotrope, it's got to be a drip, and so it's a little bit longer to set that up, and so you can push the Lasix very quickly and then set your drip up for the positive inotrope. Again, if a diuretic and a venous vasodilator both reduce preload, will you be asked to choose between these two classes? No. This is a physician decision. You just need to know what's the action, or what's the goal, what's the end game. And the end game is to make the patient feel better, because you don't want other complications because they're short of breath, and you do want to improve the cardiac function. And whenever you reduce preload and afterload, you're going to reduce the contractility, and therefore the patient may just do better without more medication. Again, questions, email me. I hope this scenario has been helpful.